Hello, I am Takeyla Williams, one of the 3 fellowship-trained breast surgeons at CHI Memorial Breast Care Associates. And today I want to discuss with you breast care and the health disparities that come along with breast care. Just to go over a couple of statistics when we talk about breast cancer. Breast cancer is the most common non-skin malignancy throughout the world. Breast cancer is the second most lethal cancer among women in the United States, the first being lung. Breast cancer occurs in 1 in 8 women. Again, that is 1 in 8 women. Your breast cancer risk increases as you get older in age. So, for example, the median age for breast cancer for minority women is 58, whereas when you compare that to our Caucasian counterparts, that is 62. So you can see that minority women are being diagnosed with breast cancers at younger ages. A little bit more when we talk about the statistics when it comes to breast cancer, there's been a considerable amount of research that has been conducted, but with limited success when we talk about African Americans and minorities compared to other ethnic groups. New strategies and approaches are needed to, number 1, promote breast cancer prevention, number 2, improve survival rates, and number 3, reduce breast cancer mortality. And hopefully the goal is to improve health outcomes and the racial disparities in ethnic minorities when it comes to breast cancer. It is vital for leaders as well as our healthcare professionals from minority populations to be represented and have decision-making influence when we talk about the research and the treatment for these healthcare disparities when we talk about breast cancer. Therefore, hopefully one day these disparities can be fully addressed and ultimately eliminated when we talk about breast cancer. The incidence of breast cancer is higher in our minority women when we talk about our Caucasian counterparts, especially the incidence before the age of 45. Minority women are more likely to die of breast cancer at any age compared to our Caucasian counterparts. And triple negative breast cancer is the most aggressive type of breast cancer, which we see twice as much in our minority populations compared to our Caucasian counterparts. When we talk about the reasons for these healthcare disparities, I always say it's kind of a multitude of reasons and it's really multifactorial. But just to give a few, minority counterparts are usually the targets of tobacco companies. Of course, when we talk about cancer of any type, smoking, tobacco use increases the risk of not only breast cancer, but of multiple different types of cancers. And if you're targeting minority communities, you can see how that may increase the risk of breast cancer or other cancers in those populations. When we talk about breast cancer and minorities as well, minorities usually have limited access to fresh fruits and vegetables, as well as a healthy nutrition. And what that means is that minorities' diets are usually higher in fat and lower in fruits and vegetables. And when we talk about breast cancer, when we diagnose breast cancer in women, we know that if you have a higher fat diet, if you're overweight, you have more fat cells that can increase the risk of you developing a breast cancer because you're making more estrogen and progesterone than the normal population or people who are normal weight with a healthy BMI. There are also fewer opportunities for safe recreational physical activity, which you can also see that leads to minorities being more overweight, i.e. making them have more fat cells and making them produce more estrogen and progesterone. And above all factors, the increase in BMI is significantly associated with a poor breast cancer prognosis. Some of the other disparities that we can see in minority communities, especially in the lower socioeconomic communities, there is a lack of screening available to those communities. Those communities are definitely diagnosed at later stages. They're more likely to get inadequate care. There also is a lack of infrastructure and resources. Some of our minority communities, they're not able to leave their community and go get a mammogram on a yearly basis. Something that may be simple to some of us may not be as feasible to our minority communities just because of that lack of infrastructure and the lack of resources within their community. There's also a lack of or inadequate health care in minority communities. The increase in comorbidities also increases the lower survival rate when we talk about breast cancer. For example, minorities are more likely to be diagnosed with diabetes, hypertension, congestive heart failure, as well as respiratory disease. Our minority communities are in general have more exposure to life stressors as well, which also increases your BMI. It could increase your weight, which affects your BMI as well. When we talk about some of the breast cancer disparities, they have a higher propensity to believe some of the common misconceptions when we talk about breast cancer. Some of those being, because I have larger breasts, I'm more likely to develop breast cancer, which is not true. The other misconception on the other end of that is that because you have smaller breasts, you are less likely to develop a breast cancer. And breast cancer can occur in women of all shapes and sizes as far as their breast size. And so that is definitely a misconception. Smaller breasts or larger breasts are not more prone or less prone to develop breast cancers. A lot of people come in and they think that because they don't have a family history of breast cancer, that means that they won't develop a breast cancer. And I tell most of my patients that I have to tell that they do have a breast cancer, that's usually the story that I get. Majority of patients come in and they do not have a significant family history of breast cancer. One of the other misconceptions that I do have to educate patients about is biopsy. Some people think that if they have to have a breast biopsy and that they are found to have a breast cancer, that this may increase the risk that their cancer will spread to other parts of the body. Me and my partners do biopsies every day, and that is definitely a misconception, something that is not true. Doing a biopsy helps us diagnose your cancer. It does not increase the risk that your cancer will spread to any other part of the body. The last misconception that I want to talk about is that most people think that if they have a lump in their breast, that if it does not hurt, that means that it is not cancer. And that is not true. Some cancers may, depending on their location, how big they are, may cause breast pain. Others may be small enough that they don't cause any breast pain. When we talk about survival statistics in breast cancer, minorities are definitely, we've shown that they have a lower survival rate when we talk about our Caucasian counterparts. You know, despite our medical improvements and our advancements in early detection, diagnosis, and screening, minority women are still less likely to obtain adequate treatment. There has been a slow and constant increase in breast cancers in minorities, while the rates of breast cancer diagnosed in our Caucasian counterparts is actually stable. The 5-year survival rates when we talk about our minority versus our Caucasian counterparts over the last 40 years is still, that difference is still very substantial. When we talk about minorities, it's an 81% survival rate. When we talk about our Caucasian counterparts, it goes up to 92%. So you can see that there's a big difference when we talk about our overall survival rates between the two communities. The mortality rate when we talk about breast cancer has decreased in recent years when we look at our populations overall. And that's due to our emphasis on early detection as well as our effective treatments. But we still notice a difference between our minorities versus our Caucasian counterparts. And although, like I said, the mortality rates have declined overall, there's still a significant difference between African American and Hispanic women when we talk about the communities, the difference in the communities. As far as some information that I want everyone to kind of know when we talk about breast cancer as well as breast health, myself as well as my partners and most fellowship trained breast surgeons or any physicians that do breast, we usually follow the American Society of Breast Surgeons. And for us, we recommend, and this is also through the American Society of Breast Surgeons, we recommend that by the age of 25, all women should have a formal assessment for breast cancer. And depending on what their risk is, determines when they should start screening, should they be referred to a breast specialist. For average risk women, we recommend that you start annual screening at the age of 40 years old. And I said annual, not biannual, not every so often, but annual breast screenings starting at the age of 40. And women should continue to have annual breast screenings until their life expectancy is less than 10 years. So when we talk about when can you stop getting screening mammograms, again, that is when your life expectancy is less than 10 years. It's not like if you get a pap smear that at a certain age, your risk of cervical cancer significantly decreases. It is actually the opposite when we talk about breast cancer. And as you get older, your risk of developing a breast cancer goes up. So if you are a good candidate for treatment of your breast cancer, we still recommend that you do annual screening mammograms. Now, when we talk about high-risk women, that may be the screening may be a little bit different. So for some women, we recommend that they start screening at the age of 30. And a lot of that may depend on their family history, if they have a significant family history of breast cancer, or if they have a genetic susceptibility to developing a breast cancer, such as a gene mutation. And I think probably the two most common that most people may know about is BRCA1 and BRCA2, but there are other multiple genes that can increase the risk of you developing a breast cancer. And so when we talk about our higher risk women, again, that may mean starting screening at age 25 to 30, depending on what your risk is. And it also may mean adding additional images such as breast MRI or breast ultrasound. Just to go over a little bit what these type of images are, maybe people don't understand what a mammogram is, or a breast MRI is, or a breast ultrasound. So when we talk about a mammogram is just a X-ray picture of the breast. We have either a 2D mammogram, and now most people know about and are getting 3D mammograms. And the difference between the two is that a 2D mammogram is just two pictures in two different planes of the breast, versus I explained a 3D mammogram is very similar to getting a CT scan of the breast. So you get multiple images of the breast, and it just allows the radiologist, it allows the breast surgeons to be able to look at the breast in a little bit more detail, helping to decrease the callback rates. When we talk about breast ultrasound, it just uses sound waves to actually make pictures within the breast. And so this does not confer any extra radiation such as a mammogram or a CT scan. There is no radiation associated with a breast ultrasound. Our last imaging modality that we usually use when we talk about breast care and breast cancer patients is breast MRI. And again, it's similar to getting a CT scan of the breast, except again, you're not getting radiation. It is actually different than a CT scan, even though it takes multiple pictures of the breast. It uses a magnetic field to make these pictures within the breast. And so a lot of people get concerned that because they have to get a mammogram, an ultrasound, as well as an MRI, that they're getting a lot of radiation. But remember, I said the last two, MRI and ultrasound, do not confer any extra radiation on top of your mammogram. Some take-home points that I want everyone to know today is that Caucasian women are more likely to be diagnosed at earlier stages with breast cancer, but our minority women are more likely to die from the disease. Poverty is linked to less education, lack of information when we talk about breast cancer prevention, as well as the lack of knowing the importance of early detection. And both of those things lead to diagnoses at a later stage, as well as a lower overall survival. 3 things I want everyone to remember is that start for average women, which will be, majority of us, you need to start your screening mammograms at age 40. You need to continue to get your screening mammograms on an annual basis until your life expectancy is less than 10 years. And if you are late getting your screening mammogram, it is very important that you schedule this as soon as possible.